Hello friends, today we will talk about the APH, which is the antepartum hemorrhage. What is the condition, what is the complication, what are the benefits, what are the complication for mother, what are the complication for baby. These all things we will discuss today in this video deeply. And what are the signs and symptoms of APH, what is the management of APH. These things we will discuss, which is very important topic for your exam purpose. So let's start the topic. Firstly, the definition of the PPH. So antepartum hemorrhage, bleeding from or into the genital tract after 20 weeks of gestational and before the birth of the baby, that is the APH. If we will talk about the APH, so APH is a vaginal bleeding during the later stage of pregnancy from about 20 weeks until the baby is born. So this condition is a medical emergency because it can be dangerous for the both the mother and the baby, potentially causing shock in the mother and harm to the baby. So it has several causes, but the two most significant are placenta previa is here. First is the placenta previa, and second one is the abruptio placenta. So when we talk about the APH, antepartum hemorrhage, then APH means bleeding from the vagina after the 20 weeks of the pregnancy and before the baby is born. So it can lead to a serious condition called hypovolemic shock due to the blood loss and making her very unwell like that, and the baby's oxygen supply can be affected with this APH condition. So this is we have to call the APH in these all conditions. These next is the when we will talk about the incidence of APH, so occur in about 2 to 5% of all pregnancies. It may be occur, and it is a major cause of maternal and perinatal morbidity and mortality. So when we talk about the incidence of the APH, uh, is any vaginal bleeding after the 20 to 24 weeks of pregnancy, and complication, it may be occur 3 to 5% of pregnancies and cause maternal and perinatal mortality and morbidity. That is the main cause of main incidence of APH. So key cause including placenta previa, where the placenta blocks the cervix, and abruptio placenta, a premature separation of the placenta. Other causes can include uterine rupture, infection, and placental problems like placental accreta. Management is an obstetrical emergency involving maternal resuscitation and fetal monitoring, and often an expanded birth, and typically via cesarean section we can prevent this APH. Affected it more than 3 to 5% of pregnancies in worldwide, and bleeding from into the genital tract after the 20 to 24 weeks of gestational and before the delivery, it is caused the APH. Now we have to see the classification of APH. So when we talk about the classification of APH, first is the major causes placenta previa. So 20 to 30% is caused the placenta previa. Through the placenta previa, it may be occur for the PPH, APH, and abruptio placenta. It may be 30 to 40% is may occur the abruptio placenta. So after that we can see the local causes like cervical polyps, cervicitis, carcinoma cervix, trauma, and varicose vein, and undetermined 30 to 40%. We don't know what is happening over there, and 30 to 40% is undetermined APH. It may be occur. So when we talk about the classification of APH by the volume of blood loss and the presence of the clinical shock, that is the APH. So the categories are spotting, straining or staining or minor blood spotting like minor hemorrhage, loss more than 50 ml blood loss with the bleeding heavy settled, and major hemorrhage is 52,000 ml of blood loss without sign of clinical shock, and massive hemorrhage we can call the more than 1000 ml blood loss and sign of clinical shock. These all are the classification of APH. Additionally, we can see the APH can be categorized by the cause such as a placenta previa and placenta abrupta. After that, we can see the spotting, staining, streaking or small blood spot observed on the underwear or sanitary protections. After that, minor hemorrhage, we can say the less than 50 ml of blood loss with the bleeding heavy settled, and major hemorrhage is 52,000 ml of blood loss but without any sign of clinical shock. After that, we can see the recurrent APH also. We can see episode of bleeding that occurs on more than one occasion, that is the recurrent bleeding. So these all are relate to the classification of APH. And minor causes is blood show due to the cervical dilatation and local lesions of vaginal or cervix. These are also the minor causes of the APH. If we have to show the blood show due to the cervical dilatation, if there will be create a cervical dilatation, and due to the cervical dilatation, if we can see the spots or bloods over there, that is also come in minor causes. And local lesions of vaginal of the cervix is also we can mention in the minor causes. So when we can talk about the etiology of APH, antepartum hemorrhage, then placenta previa, like a low implantation of the placenta covering cervix partially and fully. That is the main cause of APH. And when we can see the risk factors due to the placenta previa, so multiparity and multi-pregnancy, previous LHCS, and uterus scare, and advanced maternal age. These all are the risk to relate the placenta previa for the etiology of APH. So the main cause of antepartum hemorrhage of bleeding after 20 weeks gestational are placenta previa. So painless bleeding and placental abruptio painful bleeding. That is the main cause. If there will be feel the painless bleeding, then the placenta previa. If it is feel the painful bleeding, that is the placenta abruptio. So other cause including we can see the in placenta previa. So when we talk about the placenta previa, it is a pregnancy complication where the placenta implants too low in the uterus, covering part of all of the cervix. This condition is a major risk factor for the antepartum hemorrhage, causing bright red color and painless vaginal bleeding in the second or third trimester, and diagnosis is made via ultrasound, and the treatment goal is to manage bleeding and prolong the pregnancy, often by scheduling a C-sections once the baby is mature enough. And we can also see the four types of placenta previa over there. So complete previa, the placenta completed cover the cervix area, we can call the complete placenta previa. And marginal placenta previa, the placenta is located very close to but not completely covering the cervix, that is the marginal previa. And low lying placenta previa, we can see in this condition the placenta is within 2 centimeter of the internal os but does not cover it, that is the lower lying placenta previa. So these are the main etiology of placenta previa. So we can observe these conditions in placenta previa like in a etiology portion. Now we have talked the abruptio placenta in placenta previa. So when we can talk about the abruptio placenta etiology, then premature separation of normal slurred placenta, it is called the abruptio placenta. Risk factor is there is hypertension, trauma, polyhydramnios, short cord, smoking, fetal deficiency, sudden uterine decompression. These are the main risk factor in abruptio placenta. So when we can talk about the etiology of placental abruptio, so a causes of antepartum hemorrhage occur when the placenta premature separation from the uterine wall and leading to the potential bleeding and oxygen nutrient disruptions for the fetus. That is the main cause, main etiology of abruptio placenta. So while its exact cause is unknown, etiology is multifactorial, involving vascular damage from the factors like maternal hypertension, like substance abuse and trauma. These conditions can be affected for this placental abruptio. So other risk factors including advanced maternal age, prior abruption, and multiple gestations and preeclampsia and polyhydramnias. These are also cause. These are also etiology of abruptio placenta. So when we can see the risk factor of etiology, so hypertension, high blood pressure, both chronic and pregnancy related preeclampsia is a significant risk of hypertension, and maternal age is also risk of abruptio placenta, and coagulopathies, blood clotting disorder can contribute to the abruptio placenta. So it is a life-threatening condition. Smoking and substance abuse is also affected of placenta previa. So we can see the abnormal trauma, direct impact from a fall, accident, or domestic violence can trigger abruptio placenta. These are also main problems, and previous pregnancy complication, prior abruptio, first trimester bleeding, these are also affected the abruptio placenta. So these evidence of a previous bleeding episode can be a risk indicator. It is also lead to the abruptio placenta. So we can see the understanding the mechanism of abruptio placenta. So abruptio result from a rupture of the maternal decidual arteries which supplies the placenta, that leads to a tear in the vascular structure between the uterine lining and the placenta. So impairing blood flow is also affected the abruptio placenta, and impaired placenta, a defective trophoblast invasion into the spiral arteries and subsequently early vascularizations may also contribute to the underlying problems. That is also etiology of the abruptio placenta. So these are the main etiologies of the placental provial, and local causes is cervical erosions and cervical polyps, cervicitis, carcinoma cervix, and vaginal trauma. These are also lead to the abruptio placenta, and these conditions will be occurs is its cause is unknown. So these also local causes which is related to the abruptio placenta. So when we can talk the clinical feature of placenta previa, then we can see the painless, causeless, recurrent, bright red bleeding. These are all the clinical features of placenta previa, and soft, relaxed uterus is also a clinical feature of APH, and malpresentations common, and fetal heart sounds usually present unless severe bleeding is also present in clinical feature of APH. And when we can talk about the clinical feature of placenta previa causing APH, the painless, bright red vaginal bleeding that usually start in the second or third trimester, often stop spontaneously but recurs, and sometimes with contractions. Other features including a soft, non-tender uterus and a high mobile presenting fetal part. These is also really relate to the placenta previa clinical features, and this bleeding can range from light to heavy, and episode may be triggered by the sexual activity or a medical examinations. This is also clinical feature of placenta previa. When we can see the painless bright red bleeding, this is the hallmark symptoms distinguishing it from placental abruptio, which is typically painful, and second or third trimester bleeding, which while can occur earlier, it commonly start after 20 weeks of pregnancy, and recurrent and intermittent bleeding. Then we can see in this the initial bleeding may be light and stop on its own, but it is frequently recurs and may become heavier over time, and and soft non-tender uterus. Unlike placental abruptio, there is a typical non-significant abdominal pain or tenderness and high mobile presenting part. This is also related to the abruptio placental previa. The baby head presenting part may not be engaged in the pelvis because the low-lying placenta is blocking its path. That is also cause, and uterine contraction bleeding can be provoked by the uterine contraction or even occur concurrently with them. So these all are related to the placental previa clinical features. Maternal anemia, uterine distension, normal fetal presentation, these all are related to the clinical feature of placental previa. Now we can talk the abruptio placental clinical feature. So when we can talk about the abruptio placental clinical features, so painless dark bleeding may be revealed on concealed uterine tenderness, rigidity, hypertone, and shock and anemia out of the protection to the visible blood loss, concrete hemorrhage, and fetal distress or death commonly. These are the main clinical feature of abruptio placenta. When we can call the abruptio placenta, so vaginal bleeding, which may be absent, sudden onset of abdominal pain and back pain, and painful or frequently uterine contraction, it leads to the abruptio placenta. Other sign can include in uterine tenderness, rigidity, decreased fetal movement, and sign of maternal shock like nausea, thirst, or a faint feeling. In severe cases, fetal distress or fetal death may be present over there. That is also lead to the abruptio placenta. Clinical features, we can take the vaginal bleeding. This is the soft, often described as a dark red, but can vary greatly. It's important to the note that bleeding may be concealed, hidden if the blood is trapped behind the placenta within the uterus, and so its absence does not rule out an abruptio. So when we can see the abdominal pain, the onset of pain is often sudden and intense, ranging from cramping to the severe pain. And back pain, this may also occur often suddenly. And uterine activity, we can see the you may experience uterine contraction that are the more frequently and intense than typical labor contractions and does not relax. And when we can check the uterine tone, tenderness, so we can see in uterine tenderness the uterus may feel. So when we can talk about the uterine tenderness, so the uterus may be feel tender to the touch, and in severe cases it can become firm and board-like. And fetal movement, a decrease in a baby's movement can be a sign of abruptio placenta. And maternal symptoms, sign of the shock, such as a nausea, thirst, and feeling faint, can occur with several blood loss. And fetal distress, we can say fetal heart rate abnormalities on a monitoring device can indicate the fetus is not receiving enough oxygen due to the abruptio placenta. So these are the main clinical features which is related to the abruptio placenta. And we sometimes we don't know what is happening over there, but it may be occur suddenly and painful activities over there which can be lead to the abruptio placenta. So some local causes also affected the abruptio placenta. History of recent intercourse, trauma, and vaginal examination, and small recurrent bleeding. These all also relate to the abruptio placenta, which we have already discussed in this video. So we have to go to the next slide. So when we can talk about the diagnosis of placenta previa, then history taking, onset, amount, nature of the bleeding and associated pain, and examination, journal shock, pallor, vital signs. These are the main, we can diagnose the placenta previa with these conditions. We have to take the history collection of the patient. If previously it may be occur with that patients, that is the history, we can take the history collection. And bleeding, we can check the nature of the bleeding, how much bleeding, and which type of bleeding is maybe occur. Associated pain, painless bleeding or painful bleeding, we can assess over there. And examination, general shock, pallor, and vital signs, we can assess with this help and for the placenta previa. Now Now we can see the abdominal uterine tone. Tone is atony or flabby type of uterus feeling and tenderness, fetal heart sound, and live presentation of the baby. With the help of presentation of baby, we can assess the placenta previa. And speculum for local causes. Never digital exam unless placenta previa is ruled out by the USG. So with the help of USG ultrasonography, you can also observe the placenta previa if there will be present. Placenta previa is diagnosed primarily by the ultrasound during the second trimester of pregnancy. Third, it can also be identified after an episode of the paleness and bright red vaginal bleeding in the second or third trimester. A transverse vaginal ultrasound, which is more accurate, it is used to the confirm the placental low positions or covering of the cervix. A follow-up ultrasound at 28 to 32 weeks is recommended to check for the placental marginal. So these conditions we can assess with the help of these conditions, with the help of these बोलेंगे keys aspects for the diagnosis of placenta previa. So this is the primary method for the diagnosis of placental previa. May cases are identified during routine second trimester scan. We can assess. After that, we can see the investigation ultrasonography to confirm placenta previa, abruptio placenta, and CBC blood grouping and cross matching is also for the coagulation pathy. We can assess the how to coagulate the blood of that person, and coagulation profile we can also check over there for checking the placenta previa and cross match. After that, we can assess in this the ultrasonography follow-up and confirmation and symptoms and timing and ultrasonography. These all things we can do with the patient for diagnose the placenta previa. So when we can talk about the complication of placenta previa in the maternal side, so we can assess the hemorrhagic shock, anemia, postpartum hemorrhage, coagulopathy, especially in abruptio placenta, and maternal death. So these are the severe complications of due to the placental previa. We can assess complication of the placenta previa included the maternal hemorrhage, which can lead to the anemia, shock, and necessitated a life-saving emergency, C-section, preterm birth, potential causing lung or other developmental issues for the babies, and heavy blood loss is also, and postpartum hemorrhage is also complication of mother if there will be having the APH condition. So after the delivery there will be also increase the risk of PPH condition. So these are the main complication for the mother side, which we can which can be lead to the complication of mother due to the APH. Now we can talk about the complication of neonatal side for placental previa. So when we can talk about the neonatal side placental previa complications, so prematurity, intrauterine growth retardation, and fetal distress, and intrauterine death. These are the main complication of fetus in the APH condition. So complication for the fetus placenta previa including slowed fetal growth, preterm baby, fetal anemia, and fetal distress arising from the placental abnormalities, restricted oxygen and nutrition supply to the fetus, or from emergency interventions like C-section we can prescribe for that patients, and premature deliveries also we can face in as a complications in placental previa and APH conditions. Other risk is Apgar score, low Apgar score, congenital malformations is also the other emergency and other complications, and we can see the increased likelihood of the NICU admissions, and rarely stillbirth or neonatal death it may be occur, and fetal anemia, blood loss by the mother even if minor can sometimes affect the baby, potentially leading to anemia, and low birth weight is also a complication for in APH conditions. Consequently, babies born with placenta previa are at a higher risk of the being born with a low birth weight like less than 2 to 2500 grams, And preterm birth is also complication in APS. To save the mother's life in case of the severe maternal bleeding, an emergency cesarean section may be necessary before the baby is fully mature, leading to the preterm birth. And potentially respiratory issues is also in complication of the fetal in the APS condition. And fetal distress during labor, the abnormal during labor, the uh, abnormal presentation is also create the placenta APH. The placenta low position can prevent the baby from the assuming the usual head down position for the birth, leading to an abnormal fetal presentation. And we can see the increase in ICU admission. Preterm babies, those with low birth weight or those experiencing fetal distress, often require admission to the neonatal intensive care unit for the specialized care to that baby. So congenital malformation, low Apgar score, increased risk of SIDS means sudden infant death syndrome, and increased neonatal mortality. These are the main complications due to the APH condition, due to the placenta previa, due to the abruptio placenta. So after the complication, we should move to the management of APH, antepartum hemorrhage. When we have to talk about the management of APH, firstly we have to admit to the hospital immediately. We have to first thing is that type of patients should be admitted in the hospital immediately if there will be having this type of problem regarding the APH. After that, assessment maternal condition, vital signs and shock. You should be assess the vital signs of maternal condition and neonatal condition like FHS and positions of the baby and position of the placenta, and insert the IV lines, blood example for grouping and cross matching. If there will be having the loss of blood in a big amount, then patient will be going in the shock condition. For prevent from the shock condition, we should arrange the blood we should arrange the blood. For blood arranging, we need the cross match in between infusing the blood transfusion. So we should correct shock, anemia, IV fluid, blood transfusions. You should be give the IV fluids and blood transfusions for prevent the shock, and continue fetal monitoring. It is very necessary. You should check the FHS continuously every 15 minutes, and rest, give advice for rest. So rest is also very important, and at the time of rest, the patient's legs is elevated because it helping to prevent the blood flowing. So these conditions you should follow in APH management. Initially admitted to the patient's initial assessment method, conditions, vital signs, shock, start the IV lines, collect the blood sample for group matching, and arrange the bloods, and correct shock, anemia, IV fluids, blood transfusion. We should prevent from the shock. For prevent from the shock, we should give the patients IV line, IV fluid and blood transfusion, and continuous fetal monitoring is very necessary. And rest, give advice to the rest, oxygen if needed. You should provide the oxygen level to that patients, and also rest. After that, specific management, we should talk regarding the placenta previa. If bleeding mild and preterm pregnancy, then admitted patients and take rest, and give the corticosteroids, because the for lung maturity of the fetus, if there will be having the preterm baby deliver, then before that you should prescribe to patient corticosteroids, tocolytics if contraction is present, then you should give the tocolytic drugs. And if bleeding severe or term pregnancy, then delivery is required. You should ensure the delivery which is normal or cesarean, whatever is going on. So, and more low segment cesarean section is preferred. If you decided that times, then the priority basis of the LSCS, if bleeding, severe or term pregnancy, then immediately you should move for the LSCS. These are the specific management for the APH patient. For the shock patient, we should prevent from the shock. We should prevent from the death of uterine IUD, and we should also prevent from the lung we should give the corticosteroid for the lung maturity, and give the rest proper, and take the action regarding the LSCS. So after that, in abruptio placenta management, when we have to talk, then stabilize mother, fluid, blood and transfusion. If fetus alive and distress, emergency cesarean you should provide them. If fetus dead, induce vaginal delivery and correct coagulopathy. These management should be provided to the abruptio placenta patients. Firstly, stabilized mother, fluid, blood transfusion we should give before delivery. And if fetus is alive, fetus is not dead, that time you should immediately proceed for the cesarean section. And if fetus dead, if fetus not dead, you should take the action regarding LSCS. If fetus is dead, then induce vaginal delivery you can try, and correct coagulopathy. You should also check the coagulopathy, the blood clotting factor is working or not. These conditions you should apply on abruptio placenta. And other preventions are the regular antenatal care. You should provide the regular antenatal care. 4 ANC is necessary, and if needed we can give the more ANC for that patients. Early detection of high risk pregnancy, that is also very much important point. You should know how to detect the high risk pregnancy. There will be having the previous LSCS, previous any complications, and regarding hypertension, preeclampsia, eclampsia, twins delivery, overage, underage and overweight, underweight. These are the complications which is related to these conditions. And control of hypertensions, you should also control the hypertensions before earlier, and avoid trauma and smoking, and correct anemia and nutritional deficiencies. If there will be having any nutritional deficiency and any anemic conditions, then during the ANC period the patient will be completed them. And if in third trimester if needed these conditions, we should provide the IV infusion, blood transfusion and iron sucrose and folic acid tablets. We should provide for patient for completed the blood. So these are the essential prevention which we have to follow during the APH conditions. After that we will talk about the differentiate between the placenta previa and abruptio placenta. Then features, pain in placenta previa is painless, and abruptio placenta is having the more pain. You can apply the opposite form for the abruptio placenta. So type of bleeding in placenta previa, gathered and recurrent, and abruptio placenta you can feel the gush of the blood immediately come out, and in uterus soft and relaxed. In abruptio placenta the uterus is feel like a hard ball shape type, and fetal distress less common, and in abruptio placenta is more common. And shock, when we can talk about the shock in placenta previa, proportional of blood loss, and in abruptio placenta immediately we should provide the hospitalized, because big amount of blood loss in immediately suddenly. And malpresentations is common in placenta previa and abruptio placenta. There will be having the earlier leave the attachment of the fetus from the uterus. When we can talk about the summary, This is the complete theory on the antepartum hemorrhage in OJASVI, structure with causes, clinical features, diagnosis, complications, and management and differentiations. So we can complete all topics in this video regarding the APH. So you should follow this video, and if you have any query, you can message me. If you want more details information regarding APH, this is also comment in my inbox. And if you like this lecture, please like, comment and share and subscribe my channel and support me. Thank you so much.